Good afternoon. My name is Casey, and I will be your conference operator today. At this time, I would like to welcome everyone to the National LAN Event conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Lacey McFall, you may begin your conference.
Thank you. Good afternoon, and thank you to all of you for joining us for the National Learning and Action Network, or LAN event. We're very happy to have you with us today. We're going to be talking about some important topics of community health initiatives for health equity. Again, my name is Lacey McFall. I'm a program manager from Intelligent, and I'm with the Quality Innovation Network National Coordinating Center, or QUIN-NCC. So I want to go over a couple of housekeeping items before we get started today. Again, thank you all for joining us. And just a reminder for those of you that can hear us but do not see us, we are available in the WebEx Event Center, and you'll need to access the registration confirmation email. And then you also have a unique registration ID to log into the WebEx. Besides myself, we also have my colleague, Nora Saras from the Lewin Group, and she's going to be monitoring our WebEx chat board. So please be sure to participate as we go along, and feel free to ask your questions within the chat feature. The slides, resources, and the recording from today's call will be posted on QIOprogram.org under the News and Events tab. And some of those resources are already available. So we can see that Nora has started to put some of those resources in the chat board already, so thank you, Nora. Okay, so we're going to go over today's agenda with you real quick. First, I'm going to go over the continuing education, or the CE, details for the call today. And then I'll introduce each one of our 3 speakers. We have Melissa Dorsey with the Centers for Medicare and Medicaid Services. We have Dr. Ronald Wyatt with the MOD Healthcare Quality Institute, and Dr. Doug Campos-Outcolt from the Community Preventive Services Task Force. There will be 2 separate facilitated discussions, one after each of our speakers, Dr. Wyatt, and then also Dr. Campos-Outcolt presentations. And then finally, we're going to wrap up with a reminder about our post-event assessment, and then I'll talk about our upcoming call. So I wanted to take just a minute to remind our participants about the purpose of this important series of learning and sharing events here with the LAN series. Without reading all the content on this slide, I just wanted to mention a few high points. First of all, the audience is very broad and inclusive of a variety of healthcare provider type partners, patients, and community partners. The purpose is to offer a virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. And we would like to ask that you all think of actual ways to implement the ideas and the concepts presented for today's call, and make a commitment to share the information with your own team. And then finally, we're always open to new ideas and suggestions for topics to bring to this audience, so please do feel free to send your thoughts through the chat or through the post-event assessment. So I think Nora might also be putting in an email address for us where you can reach us as well. All right, so let's talk about the direct purpose of today's event. We will be preparing healthcare quality improvement professionals to identify and implement effective healthcare strategies by exploring promising practices to achieve individual and community health equity. All right, so we are having to make this as interactive as possible, which can be challenging because we do have a very large audience. So great to have so many of you on today. So we're going to ask that you commit to be attentive, active, and actionable throughout the call, and think about ways that the content is relative and relevant to your work and priorities. So you can share and be active and participate by clicking the green yes in the WebEx application. You can see the example that's shown here about where you can go in there and let us know that you are ready to be actionable and involved in this session. Choose yes from that drop-down menu, or you can also put something into the chat. You can chat yes. Okay, right. Thank you. I see many of you putting yes into the chat. That's great. We are very excited to be offering you continuing education credit to all attendees for participating in the session today. We offer credit to physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and certified professionals in healthcare quality. We also offer certificates of attendance. Should you have requests for additional accreditation types, you're welcome to let us know about those suggestions as well. And again, you can put that into the chat or the post-event assessment. So more information about CE credit. So in order to apply for continuing education credit, you have to do a couple things. One is attend the entire event, also complete the post-event assessment and the CE evaluation that will appear after you leave the WebEx session. Please note that your CE evaluation can only be accessed by following the application site hyperlink that's at the end of the post-event assessment. If you have any technical assistance needs related to that and to the CE process, please let Nikki Rossellis know, and Nora's going to go ahead and post her email in the chat. So reach out to Nikki if you have any questions or issues related to that process. All right, so this is a disclaimer from our partnering provider, CRW Associates. This activity awards 1.5 AMA credit awards for our credit hours for physicians and physician assistants. You can reference this slide for more information. And it also awards 1.5 contact hours for nurses and 1.5 continuing professional education units for dietitians. To follow are the accreditation statements for those entities. And another disclaimer, we would like to report that the planners and faculty for this event, CRW and Associates and Tourism, do not have any financial relationships to disclose, nor with any commercial support received for this activity. And finally, here are disclosures of financial relationships. All right, and just a reminder that you do have to participate in the entire live activity to claim continuing education credit. All right, now just real quickly, we're wanting to know who we have in our audience and what types of entities are represented. So we've got a list here, and we have a polling question that's going to come up. If you can pull up that polling question to let our participants go ahead and answer that. Give it just a second here. Okay, and WebEx, if you can pull up that quick questionnaire for the types of attendees for this perfect. Thank you so much. All right, so we have about 30 seconds here, so if you can go ahead and let us know what kind of entity or organization you represent, that would be great. And then we'll get it a little bit more time, another 15 seconds or so, and then we can pull up the results of that chat, or excuse me, that poll. And we can go on to the next slide while we wait for that to pop up with the results. I just want to go over the session's goals today. So by the end of the call today, you should be able to define health equity and understand its impact on patients, providers, and communities. Describe how the IHI Achieving Health Equity Framework can help organizations and communities achieve health equity. Describe how the Community Preventive Services Task Force supports healthy communities. List at least 2 Community Preventive Services Task Force recommendations that can help healthcare organizations to further health equity and also support healthy communities. Okay, so it looks like our chat our poll has come up. It looks like many of our attendees are from CMS, a few providers, a few hospitals, a couple representatives from CMS as well. So thank you all for participating in that question. All right, and now I'm going to introduce our first speaker, and that is Melissa Dorsey. And she is the Excellence in Operations Subject Matter Expert and Contracting Officer Representative for the Quality Innovation Network National Coordinating Center at the Centers for Medicare and Medicaid Services, or CMS. Melissa will talk about the CMS Quality Strategy and also provide an overview of CMS's efforts around driving safer care. Melissa, the floor is yours.
Thanks, Lacey, and good day, everyone. It's an honor to be a part of this call today, especially the topic matter that's going to be covered. I'm actually really excited to hear both presenters talk about the work that's happening there, as well as hear the interaction that we're going to hear today. So good day, everyone. Thank you, everyone, for joining. And the slide that you should be looking at right now is the CMS Quality Strategy. Really, the CMS Quality Strategy guides the healthcare transformation activities from the federal, the state, and the local levels, including those that are working on and within your communities. So as you see here, the CMS strategy prioritizes into 6 goals for success, which are on the far right hand of the screen. I'll read the 6 of them out loud because it translates very, very closely and very nicely into the better care, healthier people, and smarter spending. And those goals are specifically how they kind of fit into the CMS quality strategy. Essentially, they look at making care safer, strengthening the person and family care, really to promoting effective communication and coordination of care, promoting the prevention and treatment of chronic diseases, as well as making sure that we're working with communities to promote best practices of healthy living, and then, of course, making care more affordable. Again, those goals really feed into the 3 main focus areas of our CMS quality strategy, which is making better care, healthier people, and smarter spending. And, of course, we do those things with those fundamental principles that are also listed there. On slide 3, or the next slide that you see in front of you, it deals with today's topic. So today's topic for today's national call aligns with the 5th CMS quality strategy goal, which really looks at working with communities to promote best practices of healthy living. Many factors really influence the health and well-being, including individual behavior, access to health services, and some environmental and the environments where people live. So the efforts to promote these to promote lives through the access to appropriate health care, relying on deploying evidence-based interventions and strong partnerships among the local health care providers, public health professionals, community and social services agencies and individuals. Now, the objectives to help us all achieve the 5th goal really include 4 things. Really looks at partnering and supporting the federal, state, and local public health improvement efforts, improving access within communities to best practice of healthy living, promoting evidence-based community interventions to prevent and treat chronic diseases, as well as increasing the use of community-based social services and home and community-based services, also known as HCBS. Now, today you're going to get to hear from 2 passionate speakers, Dr. Ronald Wyatt and Dr. Doug Campos-Althoff. And so they're going to be providing a framework and or guides, respectively, that addresses these objectives and illustrate how communities, how they have successfully been able to work with communities to promote best practices of healthy living. So I wanted to welcome them today. It's going to be a great conversation, and look forward to hearing the interactions within this call. So thank you. Lacey, I think I'll pass it back over to you, right?
Yes, thank you, Melissa. We appreciate your insights and look forward to partnering with CMS and all of our participants on the call today and in the future. And so at this point, it's my pleasure to introduce our next speaker. Dr. Ronald Wyatt is the Chief Quality Officer of Hamad Medical Corporation and Director of Hamad Healthcare Quality Institute. Dr. Wyatt, the virtual floor is yours.
Thank you very much, and so I'm delighted to be here with you. I'm in Doha, where it's almost Wednesday. Thank you. Thanks to Lacey, Nora, Nikki, also Ms. Dorsey. I really appreciate being with you. And I have quite a bit to cover, so we'll move through that fairly rapidly. So if we'll go to the next slide, just a picture of one of the teams here at Hamad Medical Corporation, where we use the triple aim or 3-part aim as foundational for the work that's going on around safety and quality here in Doha. Next slide. So as we start to think about equity today, I think we have to all collectively understand and believe and work towards equity as an achievable goal. I use the quote here from Martin Luther King Jr. From back in the 1960s that he made in Chicago. And when we talk about health and healthcare equity, we really are talking about a social justice issue. And I think the quote that many of you have probably seen or heard before speaks for itself. Now, the next slide, please. Hello? Next slide. Hello?
So we have you, I think you're on slide 23, is that correct? Do you see that one on your screen?
Yes, there you go. Can you hear me okay?
Yeah, we can.
So sure. Okay. So the next two slides are attributed to the great work that Joe Betancourt does there at Mass General in Boston. And we have to understand the historical perspective of some of the work that's gone on around disparity and equity. And I start here with one of Joe's slides because it talks about the importance of disparity, and that relates back to the CMS strategy goals. So before we even get into a discussion about equity, let's start to understand what we mean by disparity, and that disparity must be eliminated if we are in fact to achieve health equity. So from the Unequal Treatment publication that now is about 15 years old, again, we're reminded this is not a new topic. So some of the information in that report you see on the slide there, and at the end of it, what we're talking about is healthcare disparities as a quality and safety issue, that there's variations that exist, and there's a true cost both in lives and dollars when we start thinking about the impact of disparity in healthcare. And as Joe puts there, it is in fact the epitome of low value. So next slide. If we also think back to Crossing the Quality Chasm, also published quite a while ago in 2001, which outlined the 6 aims of quality improvement, you'll see that equity is there, and it talks about how if we are to achieve equity, then we must eliminate variation and make sure that we're getting quality outcomes that are consistent for every population. And then some information there how every one of the 6 aims relates back to disparity and results in inequity. Next slide, please. So the recommendations that came out of unequal treatment you see here is part of this conversation is to increase the awareness that disparities do exist, that we're talking about a system of care, and when we start to think about ways to eliminate disparity, we need to look at how data is being collected, what that data is, how it's being used for quality improvement, is it being used to increase workforce diversity, are we truly collecting the right information and moving that to action, and do we have truly quality interpreted services in health and healthcare? Is the kind of education that's needed being provided so that health and healthcare organizations, systems, and individuals understand what this is? Is there cultural competency training? And then we'll talk a bit later about how clinical decision making has to understand the impact of disparity and equity. And are we providing information to the patients in a way that all patients, not just 1 or 2 populations, truly become activated, and the importance of ongoing research to come up with new approaches, new strategies that can be used then to eliminate disparity. Next slide, please. Again, we talk about decreasing the variations, which is just a fundamental component of achieving quality care. If we ever to have an equitable system that both performs highly and as well as a high-value system. So in the end, though, it's not just about equity for equity's sake. Cost is a key component. As we have moved into the triple aim era, disparity and equity are all population health management issues. We need to focus around transitions of care and reduce readmissions. Look at utilization of services, which includes avoidable hospitalizations, and look at overuse, misuse, and underuse as quality issues. We know that disparity and equity results in and does cause harm, and this is how it fits into the realm of patient safety, and also under the umbrella of the triple aim. What is the patient's experience? If they're from a racial ethnic minority, if that person is poor or elderly, from a rural area, whatever that demographic is, we need to have no disparity in their experience and equity in how those patients are treated when they come into our healthcare systems. And if we don't, it is at our own peril. So then, as we move from the absolute urgency of eliminating disparity, we need to understand what health equity is. And I'll go to the next slide, please. And important in the work around equity is the definition, what we would call, what is the operational definition of health equity. And go to the next slide, please. Back up one. So we described in the IHI white paper what we would call the operational definition that came from Margaret Whitehead at the World Health Organization, which is, and I quote, ideally everyone should have a fair opportunity to attain their full health potential, and more pragmatically, no one should be disadvantaged from achieving this potential if it can be avoided. Next slide. So I mentioned the triple aim, and again I list the 6 ILM aims there. What we state and what's been stated by individuals across the country, including Don Berwick, is that equity has received the least attention of all of the 6 ILM aims. Again, it aligns well with the IHI triple aim approach around population health management. So part of this conversation is to raise that awareness and to say that we need to spend much more time focusing on all 6 aims, but particular what's been called the lost aim, and that is equity. So next slide, please. So on this slide, many of you have probably seen this slide, and it talks about the difference between equality, which would be on your left as you look at the screen, and on the right, which we try to demonstrate as equity. But there's something more to this than I think we have not talked about. And as you look at that, I would say that as we think about the work that needs to be done at the community level, it's more than being able to stand on 2 boxes and see the game. So diversity and inclusion means that it's not enough to be able to watch the game. We need to find ways to move people off the fence, off the boxes, onto the field, into the stands, into the coaching box, to be the manager, to be the owner. And that's where our community programs, ongoing research, and inclusion will help to promote health equity. What that means then is that we need to start to move people from being spectators to actually being activated. Hello? You there?
Yep, we're still here.
Okay, sorry. Sounds like something else. So that means that one of the things that oftentimes we start to feel anxious about is in order to achieve true equity, then that means we have to give away something. And the one thing that many times we don't want to give away is power and authority. We cannot remove disparity and achieve health equity until we start to shift some of that power from populations that have been historically excluded to now being truly a part of the solution and a major part of the solution. So I would ask all of us, when you see this little animation, to think about it in a slightly different way. So next slide is we then move to the framework for achieving health equity that is included in the IHI white paper, which I hope all of you have or have read or plan to. That there are basically 5 areas that we focused on. One is that we, in all aspects of health and health care, make health equity a strategic priority. That means it has to be a commitment from leadership at all levels of leadership. There has to be opportunities for funding for health equity through payment models and through other funding mechanisms. Now, when we commit to health equity as a top strategic priority. The next step then is to make sure that inside our organizations, the governance also is making sure that the strategy is being executed. That means that we spread the work of equity across the entire organization. You look for, dedicate, commit resources through your budget to support equity work. And as the saying goes, we spend our money on what we care about the most. So it's urgent that we commit the resources to this work so that it, again, doesn't just become lip service. Number three is then we start to deploy these specific strategies to address what we call in the white paper the multiple determinants of health. That means access to services for sure, but are they the right services in the right place at the right time? Do we understand the socioeconomic status of our communities, where our patients are coming from, where they shop, where they eat, where they exercise, what is the public transportation, what is the joblessness issue in the community? Have we addressed people who are returning from being incarcerated? What's the physical environment in the community? What are the behaviors and healthy behaviors that we need to address that downstream leads to disparity and inequity, chronic disease, and quite frankly, premature death. Then the fourth is, we'll talk about this a bit more, is we have to address an uncomfortable topic for many of us, and that is how we begin to decrease institutional racism within organizations. And that means in every aspect of what we do. And we have some bullets there, and we'll talk more about implicit bias in a few minutes here. But part of this also is we confront what's happening in our community. That means we have to confront racial violence. We have to see power, as I talked about. This includes police brutality. It includes how we address mass incarceration, extreme poverty, access to resources, which includes access to social services. And it means how do we become anti-racist organizations. For example, at ISHOT, Institute of Healthcare Improvement, 2 summers ago, they invited in the People's Institute on Undoing Racism as a part of their effort to become an anti-racist organization. We used the example of the St. Thomas Clinic in New Orleans, which I had opportunity to visit a few years back, to look at their approach to becoming an anti-racist organization. What that means then is we have to commit to making what I would call a conscious choice to act and to challenge aspects of what we call structural racism. Next slide, please. So I think then to understand what we mean by that, because just the word racism creates a visceral reaction, but we also know that healthcare workers are not explicitly racist. We know that we have a work in a system that has some inherently racist tendencies. So a couple of again, operational definitions. One that I list here is racism is a system of advantage that's based on race. Carmen Jones talks about racism in terms of a societal box that we put people into that's based on physical features. And then that follows with some expressions of this both at a macro level and a micro level. So if we go to just the macro level first, then we start to understand what we mean by institutional racism. So that's expressed through policies and practices. The examples that I will give are the Chicago resume study that found that if a name was Emily or Greg versus Lakeisha or Jamal, Emily and Greg get invited back for interviews. Their resumes are read more often than a Lakeisha or Jamal. Another one is most recently a story of human resources firms who employees would use code words. So one of the examples was a potential employer called in and said to the HR firm person, send me a few quote-unquote hockey players. So that was code for don't send me any non-white employees. So that's an example of institutional. Well, how does that become then structural, which is way more insidious form, and this structural racism becomes normalized and it becomes legitimized, and it's there you have to start to understand the history of racism itself, which is rooted back in the whole framework of white supremacy. So understanding the history of that and how that's resulted in and actually perpetuated inequities that then is expressed in the healthcare system. So structural racism really has been called, quote unquote, a silent opportunity killer. So we have to understand and again work to dismantle structural racism. Well, then it becomes interpersonal. And a parcel is that in your face, face-to-face, or covert actions that begin to express more individual prejudice and bias. And then over time, or with time, it can become at the micro level what is called internalized. So internalized then means that at some point I began to believe and to lower my expectations. It takes away that hope that I can be healthy, that I can attain health, and I start to believe this is just my fate, that I can't be any better than I am right now because of who I am, what I look like, where I come from, what my skin color is, what my sexual preference or gender identity may be. So I internalize those things. So that can be expressed in ways other than what we think of as racism that still results in disparity and inequity. So then underneath that, back to the whole idea of structural racism, if we can go to the next slide, is what's been called implicit or unconscious bias. And structural racism feeds on unconscious bias. It is what's been described as the wall that's erected to sustain disparity and inequity. So when we think about unconscious bias, then those are the attitudes, the stereotypes that affect how we understand, how we act, what decisions we make, and it's mostly in an unconscious manner. They are activated, again, involuntarily, without the individual's awareness or even voluntary control. This unconscious or implicit bias is typically accessible through what we think of as introspection. My friend David Williams at Harvard describes this as people who engage in unthinking discrimination and are not aware of the fact that they do so. So if I go to the next slide, please. So we think about then how does unconscious bias apply? How does it manifest? And there are these templates of knowledge, and we begin to automatically categorize people by age or gender or race or role. It's mapped into our being in such a way that it influences our decisions and how we interact with individuals. So some real examples of this is when bariatric surgeons were asked to describe their patients. And three of the most common terms that bariatric surgeons use to describe their patients were lazy, stupid, and worthless. And not realizing the impact of those statements. Another one in a recent study of white medical students and residents, they have the false belief, 50% of them in the survey have the false belief that somehow black patients had thicker skin and blood coagulated more quickly than white patients. Another one was when orthopedic surgeons were asked about knee surgeries between men and women. They described doing more surgery on men because men were more active than women. So those are expressions of how implicit or unconscious bias can impact decision making and in fact clinical outcomes. So if we move to the next slide, we talk more about the characteristics on the next slide, which we know by mounds of research that implicit bias is robust, it's pervasive, it is related to explicit bias, but it is a distinct mental construct. The typically implicit associations don't necessarily sign with our true belief, our declared beliefs. We hold implicit biases typically towards our own group. One exception to that is when implicit association test was done with physicians. In fact, the group of physicians that had the lowest scores on implicit bias were pediatricians, but there was also some implicit bias when the test was applied to non-white physicians that favored white patients. And the thought there, or the hypothesis that's being tested, is that a result of some socialization that takes place during medical school and residency. We know that implicit biases, as we've talked about, have true real-world effects on our behaviors, but they can be unlearned. If I go to the next slide, please. So just a couple of clinical examples. Here is a story of a group of physicians at a major medical center, award-winning medical center in the U.S. and a team that puzzled over a chest X-ray film, not quite understanding what that film was showing, and by happenstance, the radiologist walked by the group as they puzzled over this chest X-ray film. The radiologist took a look at it, and if I go to the next slide, please. Radiologist said, that's cystic fibrosis. So the thought was cystic fibrosis is somehow a white disease. So even though the symptoms fit, the expressions fit, the patient didn't fit. So it wasn't a part of their natural thinking, which is an expression of that just implicit bias and how it plays out in clinical decision making. If I go to the next slide. Next slide. You there?
Yeah, and it looks like we had it on slide 37. Is that what you're seeing on the screen?
I'm not. Yes. So if we look at this slide, and I showed it in multiple settings, and I typically ask people, what do you see? I give various descriptions. Some folks will say, well, it's a Hispanic. People said, well, it's a gang member. Other people said, when I showed it to a group of military officers, they said, oh, that's someone who's in the Navy. So when you look at that, you say, well, what does that tell you when you just look at it? If I go to the next slide. That's the person you see there. So we've already had these reactions and mental constructs to what we think we see, but if we step back for a moment, then we begin to see the world, people, individuals in a different way. So that leads into how do we de-bias. Next slide, please. So we can go through de-biasing techniques. This comes from the State of Science Implicit Bias in the Current Institute. We need de-bias training. We recommend intergroup contact, to be around people that you normally wouldn't be around that are not in your group. Take the perspective of other people. That's what we all should be doing in health and healthcare anyway, which we call empathy. We have to measure and regulate and govern our emotional expressions and what are our nonverbal body languages. And there was a study done maybe a year or more ago where photographs were taken of medical teams as they interacted with cancer patients in an emergency department. And it showed the body language differences when the patient was black and when the patient was white. That were just obvious when you looked at the differences. And then also exposing ourselves, our trainees, our community, our organizations to people that don't fit our typical stereotypes of what's called counter-stereotypical exemplars. So when we sum that up then, we want to be able to achieve what's been called critical self-consciousness. That's to understand the society and history and how it has helped determine opportunities that define who we are. So becoming more self-conscious in the settings we're in and the environments that we're around and the people that we interact with. Next slide, please. So then specific to the healthcare, again, as I said, it's understanding the cultures that other people come from. There is a writer, Chinua Achebe, who talks about you can't come into my house through your gate. If you want to come into my house, then you have to enter through my gate and I have to give you permission, and we can start to understand each other better. And so it becomes a bi-directional interaction, and what that means is simply because you go through cultural competency training, cultural sensitivity training, cultural sensibility training, that still doesn't give you carte blanche to come into my house. That gives you an opportunity to learn more about me and some potential techniques that you can use, but it doesn't allow you then, or I won't give you permission for you to tell me who I am. And then we start to not stereotype our patients. We treat each person as an individual. Start to understand, again, that self-consciousness, to understand and respect the power of unconscious bias, recognize the situations that magnify that bias, and if we go to the next slide, please, know what the cultural and linguistic appropriate services standards are, do a teach back from the National Patient Safety Foundation, and some of that teach back is to ask me three. What's my problem? What do I need? Why is it important for me to do this? In other words, ask me what matters to me, not what is the matter. And then make sure that we practice evidence-based medicine on everyone. And that way you decrease that variation and potentially improve outcomes over time. Next slide, please. There's just a crosswalk between the class standards, and for those of you who are in the Joint Commission of Accredited Organizations, this is the crosswalk between the class standards and the Joint Commission standards. Next slide, please. That'll be slide 43.
Yeah, and I think there might be a slight delay on what you're seeing on your side of the world. We do have your slide 43 up for you.
Okay, so slide 43 is my uncle. You can see him there.
Yes.
He's from Alabama like I am, and he is a gerontologist who works now in Southern Africa. His son, my cousin, is a medical student, sent this over, and you can read through that, but I underlined three words that I think mean a lot when we start to think about how we eliminate disparity and achieve equity. That everyone, all the time, should be treated with dignity, respect, and trust. There's a long history, and then in the first slide, you saw mistrust. That mistrust goes back through what happened at Tuskegee Institute, to the Henrietta Lacks story, back to the work that was done around this in Tuskegee, back to W.E. Du Bois, who published something called the Philadelphia Negro in 1899, where he stated that looking at his data, that was a well-done study, there was what he described as a peculiar indifference to the Negro in the work that he had done. And you can take that again back to what's been called the original sin of slavery that has impacted, still continues to impact this topic that we're speaking of today. But at the end of it, we're talking about, I think, those three words. And then to the next slide, and many of these conversations when I present, I talk to people, they say, well, this is too big. I can't do this. I'm just one person. So I sum that up this way, and another quote by Martin Luther King that says, if you can't fly, run. If you can't run, walk. If you can't walk, crawl. But whatever you do, when we start to think about everything we've talked about with disparity and equity, we have to keep moving forward if we're going to eliminate disparity and achieve health and healthcare equity. So the next slide is just the front page of the white paper that I hope you all will read and share and try to understand. But it's just an ongoing effort to not only just raise the awareness around disparity and health equity, but really to start to say, here are some things that you can start to do to mobilize action. There are lots of other great work that's been done. The American Hospital Association's 1, 2, 3 Equity that's led by Thomas Leon, the work that Bruce Siegel and the group is doing at American Central Hospital, and the great white paper that they published a couple of years ago. So there's a lot of activity around this topic and frameworks and guidelines that we can collectively start to work on to try to accomplish this tremendous goal. The next slide then is just a summation of a recent paper that Kate Armate and I wrote. Just some bullets on what we read through those. I'll encourage you to read that paper because it talks more about the IHI white paper and that framework and some ideas about how you can apply that down to the community level, which is an absolute must. So the next slide. That is my Aunt Molly. She was like a mother to me, and if you read the white paper, you'll read about her husband, Tom Cannon, who was a father figure to me, a great uncle. Before I talk about her, and that's where I'll end, I want to remind you that the UN Working Group of experts on people of African descent issued a report in 2016, and I quote them. And they say, despite some gains, the legacy of colonial, historical enslavement, racial subordination, segregation, racial terrorism, and inequality in the U.S. remains a serious challenge. So when I was in college, I talked to Aunt Molly, the lady sitting there, and I said, you know, you grew up in Perry County, Alabama. You grew up not really being allowed to go to school or learn to read and write much after the 4th grade. And I talked about how my Uncle Tommy, even as I recall, he could not look at a white person in the eyes. He would hold his head down even when he was in his 60s and later years in his life. And I talked to her about how in the world they could have survived and how they did that. So I was asking her, what is the secret? How do you survive this? And she gave me, even as a teenager, I think my first lesson in health equity. And that's why I said, what is the secret? She said, what you have to do is love everybody. And what she said was, you got to love people. And I think as we think about the approach to eliminating disparity and achieving equity in any work around quality improvement for any population or any group, however that group identifies themselves, is the work of achieving health equity is work that's just rooted in loving people, loving all human beings. If we can start there, then we truly can say we're going to work on eliminating disparity and achieving health equity. And I will stop there, and I thank you very much for your time. And I know I threw a lot at you, but I'll stop there. Thank you.
Thank you, Dr. White. I really appreciate it. Thanks for your thought-provoking presentation and for bearing with us with some of the delays with you across from the other side of the world. But I think at this point we're going to go ahead and open it up for questions and comments for Dr. White's presentation, and a reminder that the chat is available. So if you have some questions you want to turn to the chat or comments, please do that, and we'll have Nora bring those up for our speaker. And then also, operator, can you let attendees know how they can get into the phone queue if they want to ask a direct question?
Yes, certainly. So as a reminder, if you would like to ask a question over the phone at this time, please press star followed by the number 1 on your telephone keypad. Again, that's star 1 if you would like to ask a question over the phone.
Thank you. All right, Nora, I am going to pass it to you to see if you have any questions in the chat that you'd like to bring up.
Hi, yeah, thank you, Lacey. I do have one here from Andrea Moore, and she writes that I find a certain language can unknowingly be very offensive. In discussing compliance and noncompliance with a Black male patient, he stated that given the history-race relations, the term compliant was very offensive to him. Are you aware of more acceptable language around the topic of a patient's acceptance to a medical plan of care?
So thanks for the question. I would say that I stopped using the term non-compliant probably 10 or more years ago. Underneath that also, we have to start to adjust what is health literacy and what that means. And typically I started using the term adherent or not adherent. And I don't know if that's the perfect way to put that also, but I find as a patient myself, the term non-compliant was, I would call it a micro insult. And I've had that experience with healthcare professionals when, they would say to me, well, this patient was non-compliant. And I learned early on in my training that if you describe that patient as non-compliant, then in some ways as a healthcare provider, I would ask you to step back and become a bit more self-conscious and where have you failed that patient? And that's part of self-consciousness, to be sensitive to those words and again, the things we talked about. But I would urge everyone to think of using some terminology, and I will say that with all patients. But particularly, I think it's been used in my experience with non-white patients, that patient is non-compliant. It's a negative connotation, and it almost says that, I give up. And if you take that approach, that goes back to that internalization that I talked about. When a patient will say, well, that doctor doesn't care about me. I'll just do the best I can. I won't take the medicine. I won't undergo the procedure. So it feeds back into the whole mistrust cycle that continues to perpetuate the problems of disparity and equity. And I do think that the whole idea around prejudice bias and particularly implicit bias comes to play in those kinds of words that we use. So I would urge everyone to look at the words we use and understand the power of the words and understand what we mean by micro insult and a micro assault. Those are hurtful things. So we have to be sensitive to those and provide the education to our care teams and ourselves about what they mean and the harm that they truly can do.
Great question. Thank you for your response. Nora, do we have anything else in the chat?
Yes, there is one more question here from Christine New York. And she says, is there a negative connotation to the term educating the patient? For example, regarding meds or lifestyle intervention, or would counseling be a preferred term?
Well, once again, the terminology and phraseology and the context of when it's used, there are many people that we could say we will provide some additional education. I think if you say, I'm going to educate you, or you need education, or I'm educating you, yes, and how those words are used, and there's studies to look at, again, body language, the tone, how loud you speak, when you use those kinds of phrases that can impact patient care, and again, trust that there are other cultures where the approach may be different. So it's understanding the culture of the patient that you're interacting with and thinking again about population health management, it's inviting people in from that population to assist you with your communications. So for instance, I visited one organization where they had a problem with readmissions and they looked at what was driving their readmissions. It was one particular population. So they asked a person from that community, it was an ethnic community, to come in and look at, observe what they saw in the patient interaction with the healthcare team. And it did not take long. What the community person said to them is, in this culture, when you give instructions at the time that patient's transitioning out, the instructions should go to the male person first. If you don't, then it's considered disrespect, and the male person, which could be husband, brother, father, grandfather, would see it as disrespect and would not allow the female, who is the patient, to follow through, to take the medicine or get the prescription filled or to follow up, and then that was contributing to the readmission problem. So you begin to understand those things and how you can adjust your communications to improve outcomes for the patients. I hope that helps.
Thank you. And I see some discussion that's happening about the term adherence. So thank you for those of you who are chatting and communicating to the chat. And I'm going to break in for just a second and ask our operator, Casey, if we have anyone on the line who has a question.
There are no phone questions at this time.
Thank you. Nora, any other comments or questions that we should bring to the attention of Dr. Wyatt?
Hi there. There are no more questions right now, but there seems to be a lot of positive feedback, so thank you so much for the presentation. And Kim also just let us know that Marshall Rosenberg has an excellent YouTube series of segments on nonviolent communication as a tip for everybody. I will repost that in the all participants chat.
Thank you. Thank you for sharing that, Kim. And I know Dr. White might need to step away from the call after his presentation here, so if you have other questions or comments that come up after we move on to our next presenter, we'll see if he might be able to address those later. Dr. White, do you have any other final thoughts or comments you want to share with us before we move on?
Just one thing, and I know I have to drop off, and I'm happy to, if you email me any questions, I'll try to respond to those. But I think that another thing that we need to leave this with is where I started, that this is achievable. That as we at IHI say, we say hope is not a plan, but I'm more hopeful that we can start to eliminate disparity, and we can achieve health equity for every population. That's the hope that I have, and I'm extremely optimistic that moving forward, we will make a huge impact in both these areas, both disparity and equity. I cannot emphasize enough the importance of not just workforce diversity, but true inclusion. That means who is in the boardroom. We know that if a board of directors in any setting, but particularly the studies show in healthcare settings, if the governing board is at least 10% female, there is increased profits, there's increased creativity, there's more innovative thinking. So we have to think more about not just numbers of workforce diversity, but then what happens next? Is there true inclusion, and does that align with your workforce diversity, and are you truly getting the voice of the community that we're all called to serve? So it's been fun, and it's been an honor, and I would just encourage you to read the white paper, move forward with some plans, make health equity a strategic priority, and I just really thank you. I'm going to have to drop off.
Thank you so much, Dr. White. We really appreciate hearing your insights and learning about your work in achieving health equity. And one last ask of our intercall operator, if we have anyone on the line with a question.
Again, there are no questions over the phone at this time.
Okay, all right. I think we'll go ahead and move forward. One last comment about the white paper. We put the link in the chat, so if you haven't seen that, you can find that in the chat and link to it. You may need to create an account. There's no payment or anything associated with that to access the paper, but that's how you can get a hold of it. And so I think we'll move on, and now it's my pleasure to introduce our final speaker. So I think I want to advance the slides before. Thank you. Dr. Derek Campos joins us from the Community Preventive Services Task Force. He's also a medical director for Mercy Care Plan, a Medicaid health plan in Arizona that's serving 300,000 members. He's a member of faculty at the University of Arizona College of Public Health and the University of Arizona College of Medicine. Dr. Campos, the floor is yours. And I think we're going to go ahead and pass the ball to you.
All right, thanks very much. Can you hear me okay?
Yes, we can. Thank you.
Okay. So I am going to advance my own slides, I hope. Okay, so far not advancing.
Okay, it might be just a slight delay here. I think on our end we see that it has moved. There should be a message that pops up.
Nope, still hasn't advanced, at least on my screen. And I was seeing the slides advance as you were doing it previously, so I don't think it's working.
Okay, give us a second here. We'll see if we can get that fixed for you.
Okay. If not, let's just go back to having you move them, and I'll tell you when to switch slides, so we don't spend a lot of time.
I'm going to just try a little test here. At the top of the page, if you push on the arrows on the right where it has the slides, does that move the slides for you at all?
Oh, hang on. Now,
I think, yeah, see if you can you advance the slides from here?
no.
With your arrow, maybe just the arrow keys at the bottom of your...
Yeah, try both. Yeah, try both my...
The page up or page down? Okay.
Right. Now, page up, page down. Let me try that. Yeah, that works. Okay. All right. So, I apologize for that. So, we're going to talk about some evidence-based resources that can help you implement some strategies where there's evidence behind them. And I think it's very important that when you're doing clinical services as well as public health and community services, that you put your efforts behind interventions that there's some evidence that they work. We found out in medicine some time ago that not everything that was proposed turned out to work as hoped. And so the evidence-based medicine movement became particularly strong in prevention. And the three organizations that currently make recommendations based on evidence-based methodologies include the following you see on this slide. The United States Preventive Services Task Force, and that's probably one of the best known. It makes recommendations on individual clinical preventive services, such as screenings, health education, counseling, and so forth. And they have a well-developed evidence-based methodologies, probably the gold standard in this country and outside this country as for how to make an evidence-based recommendation. The Advisory Committee on Immunization Practices makes recommendations on vaccines and immunizations. It's an advisory committee to the Centers for Disease Control, and it meets 3 times a year and makes recommendations on vaccines. And they're also evidence-based, and their methodology it's a little different, and it's evolving, but it's also based on an assessment of evidence. The Community Preventive Services Task Force is the newest, and it makes recommendations, again, using an evidence-based methodology. The evidence is assessed, and recommendations are made according to what the evidence shows. But these are interventions regarding health services, health systems, and communities. So they're more public health type recommendations. The task force is an independent, the Community Preventive Services Task Force, which is what we're going to focus on here, is an independent, non-federal, non-paid panel of public health and prevention experts. 15 members, each serves a 5-year term, can be extended, and they perform several tasks, including overseeing the systematic reviews of the topics that are chosen and producing recommendations based on the evidence. I am serving my first year as a member of this Community Preventive Services Task Force, and I was pleased to be picked to do that. Previous to that, I had served on the Advisory Committee on Immunization Practices, 6 years as a liaison and 4 years as a member. I also was able to spend 6 years as a liaison to the U.S. Preventive Services Task Force, so I've seen all of these groups in practice. The U.S. Preventive Services Task Force was first formed in 1986 because of a perceived need to get better evidence of what preventive services worked and which ones didn't, and as a guide to clinicians. Throughout the 80s and the middle of the 90s, the public health community began to discuss whether it would be a good idea or not to create a similar type process for public health interventions. And in 1996, the Department of Health and Human Services established the Community Guide, which is a compilation of the recommendations that come out of the task force as a resource for communities and the public health infrastructure. The staff is provided by CDC. The subject matter experts are provided by the CDC. But the task force is independent and makes independent recommendations. So the task force was established to produce this community guide. So the guide consists of a series of state-of-the-art systematic reviews on a variety of topics, where on that topic all the available evidence is assessed, and particularly regarding the effectiveness when it's applied in a population setting. So it's there to assist communities and healthcare systems and to assess interventions that are applied at a community or health system level. The economics of these proposed interventions is also assessed, and then each assessment ends with a description of the evidence gaps that might exist. If there's certain key questions for which there's no literature, then this is described in every systematic review. There are some legislative requirements that the task force is to fulfill, including developing a list of topics for new recommendations, updating existing recommendations every 5 years, coordinating and integrating with the Healthy People objectives and targets that are set, developing tools for dissemination of the recommendations, providing technical assistance to those who request it when they want to implement the recommendations, providing a yearly report to Congress, and coordinating with the U.S. Preventive Services Task Force and the Advisory Committee on Immunization Practices. You'll frequently see a recommendation that complements one made by these other two groups. For instance, the U.S. Preventive Services Task Force has recommendations on who should receive screening for certain cancers, colon cancer, breast cancer, cervical cancer, and the community Preventive Services Task Force has developed recommendations on how you can increase the number of people who receive those screening tests. Same thing for immunizations. ACIP makes individualized recommendations on vaccines and who should receive them, and the community task force has recommendations on how to increase the uptake of vaccines and to get more people vaccinated. So the CDC provides administrative, research, and technical support to the task force, but once again, the task force deliberations and decisions are independent. So here are the steps that the task force goes through when making a recommendation. The first step is to prioritize topics. There's a solicitation for nominations of topics. Individuals and organizations can submit potential topics. The task force then reviews these and ranks them as priority using a number of variables such as how many people affected, how important of a health topic, and so forth. Equity is a very big consideration in the topic prioritization process. And then they will develop a list of topics with highest priority to be forwarded for the systematic review and recommendation process. The second tier on this slide shows that the next step is to evaluate the effectiveness through a systematic review. And this involves all the steps of a good systematic review, defining your questions, doing comprehensive literature searches with inclusion-exclusion criteria, assessing the quality of individual studies, and assessing the overall quality of evidence. Next, it determines how applicable it is to various populations and settings, and to conduct an economic analysis. And then all this information goes through the task force. And the last series of steps is the task force reviews this, comes to a decision, usually a consensus regarding the conclusions and the strengths of the evidence, and then makes a recommendation and works on wording for the rationale statement. So this is kind of a diagram of some of the issues that are considered in the systematic reviews. So you have an intervention, which is either a program, a policy, or a specific clinical intervention of some kind. It affects a population or a group. There's some hope for outcomes in either behavior or health, and then this hopefully results in reduced morbidity and mortality. And then the question is, does this intervention apply to the population that we have of interest in? For the community task force, that means the U.S. population. Look at costs and economics. So you look at the costs of the intervention, the benefits derived from the intervention, and the economic benefits from that, and that goes into then the economic analysis. The intervention itself may have additional benefits or harms outside of the pathway that you've originally studied. And we look at those too. Various interventions have additional benefits outside of the ones that you initially might be interested in. And then you look at considerations for implementation. Is it a practical recommendations cannot be implemented. In most cases, there are barriers to implementation that would keep it from being a practical consideration. This kind of is a table of how we translate as a task force the evidence, and we rate the evidence as being either strong or sufficient or insufficient. The expert opinion word there we don't use very often, but we don't like to make recommendations based only on expert opinion, although I understand it has happened. So you can see the criteria that I looked at in terms of the evidence, the studies that are reviewed, the quality of the execution of the studies, the suitability of the study designs, the number of studies found, the results being consistent with each other, and then was the effect size of the intervention. Did the intervention achieve a meaningful effect or not? Those are all considerations that then can lead to a strong recommendation based on the various boxes, which I won't go into in a lot of depth. Or do we consider sufficient evidence to make a recommendation, or do we consider it insufficient? And that will be described. You'll see if you go to the task force website and look under a particular topic. There may very well be the topic listed, the intervention listed, and then to the side of it may be insufficient evidence, meaning we just don't know if that works or not because the evidence is just not there. That evidence report will have a lot to say regarding gaps in the evidence. So when once the task force has these findings and these recommendations, what happens to them? So they're published on the community guide website, and various stakeholders use them for various purposes, such as developing local policies, beginning discussions on certain topics. Many of these topics are somewhat controversial, and at times the best you can do is begin dialoguing about them. The reports can inform research priorities. Gaps in the evidence base are listed. They can help people evaluate their programs. Mobilizing the community. If you're doing a program now or implementing a project that there's evidence for, you can help justify your existing program. And it can help in planning and enhancing future efforts and getting funding, as well as educating policymakers and communities for them developing strategies. So there's a number of uses that the recommendations are put to after they're published on the website. And in addition, there's a dissemination strategy beyond just publishing the recommendation. There's a number of other ways the results are sent out. So this is two examples of how we go from a strategy to a program and policy. One of the topics is to reduce, or goals was to reduce obesity. And one of the recommendations was to reduce screen time, meaning television, video games, and so forth. This has been shown to help reduce the prevalence of obesity. And then the task force, the community staff produced a tool, the TV screen reduction tool used with youth. And that's available to anybody who might want to use it to help implement a program like this. The second one was to increase physical activity. And the strategy that was looked at was point of decision prompts to encourage screen use. And there's an intervention that was developed for that as well. And there's resources to help any community or organization that wants to implement that strategy. So the results and the materials are disseminated from the task force in a number of ways, including announcements, press releases, promotion to other government sites, email lists that are kept. Many organizations are partners of the task force, and they're notified when they disseminate the results to their members. The task force staff often conduct webinars, and then they produce fact sheets, policy briefs, and have conferences. And I don't know to what degree they're using the newer social network at this point, but I know that there's been a lot of discussion about that, and that is being used more frequently as well. One of the useful resources on the website is a little section you can go to where there is a description of what communities have done, some examples of where the community guide recommendations have been used successfully in communities and how they went about doing that. And that's, I find to be very interesting case studies of the implementation of these recommendations. So here currently are the topics. If you go to the community guide website, you'll see a tab for topics. These are the topics that will come up. The ones that are circled have a great deal of pertinence to today's topics and achieving health equity and increasing quality. And I understand there's going to be a list of resources available on the website that's going to be posted as a follow-up to this conference. And there may be some more that should be mentioned about that after I conclude my talk. So here's what you do if you go to the Community Guide website. It's very easy to find. You can either type in Google or any other search engine, Community Guide or Community Preventive Services Task Force, and this is where you'll end up. You can see the topic tab up there. If you go to the task force, it tells you who the task force members are and how the task force operates, and then the publications and resources are there. It's a very useful resource, I think, for those who are interested in looking at and finding interventions that have evidence behind them that can address some really pressing population health problems. So that concludes my presentation, and at this point I'm happy to take any kind of questions there might be.
Wonderful. Thank you so much, Dr. Campbell-Belcourt. And I think at this point, are you able to pass us back access to navigate through the WebEx?
Yeah, who should I give it to? Nikki?
To Nikki, please, yes.
Okay, hang on. Give it to the wrong person. Okay, I think I just did it. Yeah.
Yep. Okay, wonderful. Thank you so much. And at this point, I think we're going to open up for questions for you. And Casey, can you remind attendees again how to get into the phone queue? And then again, for those of you who would like to put your questions or comment, you can do that into our chat board. And we'll have Nora bring those comments and questions to our speaker.
Again, as a reminder, if you would like to ask a question over the phone, please press star followed by the number 1 on your telephone keypad. Again, that's star 1 if you would like to ask a question.
Thank you. And Nora, do you have any comments or questions in the chat that you'd like to bring to our attention?
Hi there. There are no questions right now, but there is a lot of positive feedback. It looks like Rachel Eichenbaum just commented, where do you get your funding for the website, etc.?
Yes, the funding comes from the CDC budget. And it's, because the funding is mostly for staffing. The task force itself, we get minimal per diems for our days that we spend there at the task force meetings, but the main cost is for the staff. And that's part of the CDC budget. And, as with everybody else in government right now, I suppose we're all kind of waiting to see what's going to happen with that in the future.
Thank you. And just a question for all of our participants today. If you have questions, like we said, please do dial into our queue and we can get you on the line to talk with our speaker or put your question or comment into the chat. One thing I would hope that you think about is, one of the things that actually that we're interested is knowing from our participants is whether or not you have aligned any of your interventions or any of the ones that you're doing in your activities related to the community guide. So are there any, have you used the community guide for any of the work that you've done locally? And if so, we'd love to hear from you.
Well, my comment that if you peruse the site and begin to look at the different interventions that have been studied, I think you'll be impressed by the array of them. Most of these were done prior to my appointment to the task force, so I can't claim credit for them. But for instance, on alcohol use, there's a lot there regarding the environment and the community environment, such as number of alcohol outlets within a certain area, the kind of data, and different retail options that you can implement that result in lower alcohol intake and lower other measures of alcohol misuse. And I rather repeated before I said before, some of those can be quite controversial. And under tobacco use, there's a number of recommendations there regarding how to decrease the amount of tobacco consumed. And again, there's certain aspects of the society who find those to be very, very controversial, but that's what public health is about. And if you're going to implement something, it's my view that you should, if it's really controversial, you should at least try to have something where there's some evidence that it actually works. And that's where I think the task force recommendations can be very, very useful in discussions that can become somewhat contentious at times.
Thank you for sharing that information. And Casey, do we have anyone who has dialed into the queue?
There are no questions over the phone at this time.
Okay, and I wanted to highlight something that Dr. Campos talked about earlier, where he mentioned some of the, and circled, maybe we can go back to that slide, circle some of the areas that are directly relevant to the quality improvement organizations. We'll get that up in just a second. As he mentioned, we are compiling a list that we're hoping to post and make available on the the QIO program website, as well as healthcare communities for those Clean QIOs on the line. So we'll talk about the different quality improvement organization task areas and how some of the community preventive services task force, some of the interventions are directly applicable to those task areas. So just wanted to highlight that again. And finally, I guess one more question from the operator, if we have anyone who has dialed in.
No questions over the phone at this time.
Okay. All right. Well, Dr. Campos, thank you again so much for presenting today and providing this great information for our attendees. And I think we'll move on to our next slide. Just a reminder to review the call resources. So we have put a couple of those resources into the chat for you to pull up at your leisure. But we hope you will take a moment to look through the community guide as well as the IHI white paper presented today. Maybe identify community partners that you can engage with in your own efforts locally. And as I mentioned, we do have these calls quarterly, and just some information about what we're going to hear about in the future. One of the things I wanted to point out is that if you have topics that you want us to share on these calls, please do let us know. Please put in our contact information. You can let us know in the evaluation as well. But we want to make these calls relevant to the work that you're doing, and certainly appreciate feedback related to that. And then for our next call, which is going to be on May 2nd, 3 to 4:30 p.m. Eastern Time, we have another LAN event. Registration is required, as always, for these calls. Again, we'd like the opportunity to engage with you and hope to do it again in the future. And that next call is going to be on promoting beneficiary and healthcare worker immunizations, addressing barriers. And like I said, please remember that registration is required for that call. And finally, I just wanted to thank everyone for joining us today. Please do feel free to submit any additional or final questions you have to chat. We can capture those and share those with our speakers. And also a reminder that when you close the WebEx session, you'll be invited to share your thoughts and feedback through a post-event assessment. We greatly value this feedback and appreciate you taking a couple minutes to complete that for us. And I'd like to thank all of our speakers today, Melissa Dorsey, as well as Dr. Ronald Wyatt with Ahmed Healthcare Quality Institute, Dr. Doug Campbell-Colt with the Community Preventive Services Task Force. And again, thank you to all of you for joining us today. Have a great rest of your afternoon.
And ladies and gentlemen, this concludes today's conference call. You may now disconnect.